there are plenty of other issues that, face everyone, and gamers in particular. So I wanted to address one of the more prominent ones tonight, which is repetitive stress injuries. So if you look into the literature, so I'll refer to the literature quote repeatedly. That basically means like research, scientific and like medical research, the body of studies that address something. So it's not just like Shakespeare and stuff. This is like specifically scientific, peer-reviewed research. So anyway, if you look at research regarding repetitive stress injury, it's actually pretty murky. There's not a whole lot of like good quality sound evidence that repetitive stress injury is a thing. So there are lots of things in science that we just sort of like, what's a good way to put this? We just sort of know that it is the way it is, but it's very difficult to demonstrate. And sometimes we also just like do things according to common sense, whether or not that's actually supported by data and research. So, like if you game for 15 hours straight, from experience that like, your hands and your wrist cramp, right? This is just obvious. As to whether or not that actually will cause you an injury is up for debate. But what is generally, oddly enough, what's generally agreed on regarding repetitive stress injury is how to manage it. Which, given that people can't really agree that it exists in the first place, is kind of confusing, but we'll roll with it. I am not an orthopedic surgeon, clearly. I'm an anesthesiologist, just to be, 100% transparent about this. So I am not an expert on, like musculoskeletal disease or therapy for it. So this is all based on my sort of peripheral knowledge of what's going on and, my ability to read these scientific journals and interpret the information. So again, I am not an expert on this particular topic. If you have a repetitive stress injury and you are interested in getting it evaluated, please go to an appropriate physician, whether that's an orthopedic surgeon, your primary care doctor, a physiatrist, whatever. This is, just sort of an educated opinion on what's going on. And I will keep this as factual as I can. So, what we most commonly think of repetitive stress, or what I most commonly think of as a repetitive stress injury, is carpal tunnel syndrome, right? So that's where essentially your median nerve, which is the nerve that supplies like most of your hand, gets entrapped in your wrist, like here. So it goes through the carpal tunnel. And there's a couple like tendons and your median nerve that go through this like sheath of connective tissue. So the thought is that one cause of repetitive stress injury is sort of like continual low-level inflammation, and that eventually leads to some sort of kind of, not necessarily scarring, but like thickening and sort of like, what's a good word, like increased density of the tissue that sort of clamps down on your nerve and your tendons and irritates them. So with that in mind, things that help are anti-inflammatories. So things like ibuprofen, Tylenol even straight up is kind of a, not really generally thought of as an anti-inflammatory, but it does work on the same enzyme system that ibuprofen does. It's a COX-3 inhibitor, whereas ibuprofen's a COX-1 and 2 inhibitor. That's cyclooxygenase. So, yeah, they inhibit COX. That's right. You heard it here first, folks. That's kind of like, first line sort of stuff. So other than that, like, conservative therapy is like not, we've all heard the joke that says, hey doc, it hurts when I do this, and the doctor says, don't do that. Well, that's actually really good advice. So if you're having symptoms of carpal tunnel syndrome, or, like your fingers or hands are cramping, stop doing what you're doing, like give it rest as much as you can. That all falls under the umbrella of like physical therapy, right? So another thing you can do is like stretch, basically. Stretch, take breaks, rest, exercise. So like dedicated like hand or wrist exercises can help like strengthen those tissues instead of just relying on what you've got to kind of push through. I know that goes against the rest thing, but you kind of try to take advantage of the opportunity to exercise when you're not having symptoms. If you start having more advanced symptoms, that stretching and rest and things like that don't treat, you may have to consult your doctor, and then you can start working in things like braces. So orthopedic surgeons will often, they have a sort of schematic, I guess I'd say, for any sort of like soft tissue injury, and sometimes hard tissue injuries too. But the acronym is RICE, which stands for rest, ice, compression, and elevation. So, hey Maven, what's up? So yeah, if you're having like, kind of long-lasting serious symptoms from a repetitive stress injury, try those things. Rest it, ice it, compress it, elevate it. There are lots of braces that are available for compression. There are like compression like sleeves, or if you're having an RSI in your feet or legs for whatever reason, there are like TED hose and compression stockings and stuff like that that'll help elevate your limb, your affected limb above your heart. It helps prevent swelling, which can sort of double down on the symptoms, basically. Like it just, fluid just takes up more space, and you're already dealing with kind of like an inflammatory process. So anytime you can get the fluid away from that inflamed area, then so much the better. So ice is kind of self-explanatory. You cool it. So that's conservative therapy. So everything from just not doing what hurts you to taking meds, over-the-counter anti-inflammatory stuff should be perfectly fine. And, you can progress to, like, working with a physical therapist. And then the final frontier of RSI treatment is surgery. That is sort of, it's, it's last resort. Like, carpal tunnel surgery with a skilled surgeon is a sub 10-minute surgery. It is very, very fast. You don't have to even necessarily be technically under general anesthesia for it. A lot of times they'll do, so this is where I come in, right? This is where I am an expert on things that happen. So we'll do something called a MAC, which is short for monitored anesthesia care, which basically means you are, for all intents and purposes, asleep. You will not remember anything, you will not feel anything, but you're not technically under general anesthesia. You're breathing on your own, and all of that, and you'll wake up pretty quickly afterwards, and recovery is short. So basically we just kind of like stun you with some drugs, and the surgeon will come in and inject numbing medicine around your nerve that just takes your hand out. So like you won't be able to feel your hand for, a couple hours, basically. If he feels like he needs to get, if your surgeon feels like he or she needs to get a little bit more invasive, a lot of times you can do sort of a next level version of that nerve block thing, but do it like up just right above your shoulder, and that will take out your whole arm, and it'll also last a lot longer, and your anesthesiologist will do that most likely, not your surgeon. That'll still allow you to be technically awake during your procedure, but it'll kind of let your surgeon get a little more invasive and dig around some more, without bothering you, basically. So the short story is that most repetitive stress injury issues are pretty easily treated, because carpal tunnel syndrome accounts for the vast majority of surgically treated RSIs. Elbows are a little more complicated, like tennis elbow. That generally requires that nerve block I was talking about. Generally, it's called a supraclavicular block. Is the one that you'd get for that. And that's just because of nerve distribution and like the location of the injury. But in any event, and recovery from that is a little bit, more intense than a carpal tunnel would be. I actually cannot recall having done any therapy for lower limb repetitive stress, surgical therapy for lower limb repetitive stress. Though I'm sure I probably have and just maybe didn't know it. But that's much less common than wrists and elbows in any event. Oh shoot. I just leveled up Ice Golem and I don't know. Well, I should have enough decks for that. Okay. So yeah, that's the like kind of skinny on repetitive stress. So ergonomics is kind of a big topic in that area these days. So like I mentioned, the hardcore science types can't really necessarily even agree that repetitive stress injury exists. As such, like it's not necessarily an injury, even though we can pretty well all agree that, something happens after years of using and abusing your hands. I don't have I don't have any useful hard data to work with for this statement, but I can tell you that ergonomics have, I believe, helped me personally a lot. And generally, if you look at the papers that support them, this seems like a pretty decent jewel. Shock duration and burning damage? Might be kind of nice with an elementalist. Anyway, ergonomics is kind of like a why not sort of thing. Like, what's the drawback to having, an ergonomic desk or mouse or, keyboard or whatever? Like, there's, no reason to not do it. So, do it, kind of thing. So I do not have an ergonomic keyboard, but you can probably see here I have a vertical mouse. Because I was actually sort of, exhibiting some symptoms of like repetitive stress injury in my hand, not necessarily carpal tunnel, I don't think, but my hands were like cramping fairly easily, so I felt like I would give this a try, and I honestly think it's made a big difference. So your goal with ergonomics is to essentially keep everything in a neutral position. So, like, the easiest way to think of that is just to kind of like stand up and take note of where your body is. So like a typical mouse is like this. You don't stand like this, right? You don't stand with your hands like this. You stand like this, right? So that's why a vertical mouse is nice, because you just kind of lift your hand up and just put it straight forward, and you don't have to change the orientation of your hand. So same deal with like an ergonomic keyboard. So instead of going like this, which is, what a normal keyboard does, like the keyboards that are sort of like flared in the center, let you go like this, which is a much more natural position. Same deal for like those like ergonomic like stool chair things that don't have a back, where you like, I'm going to describe this really poorly, but basically you put the weight like on your knees and your butt, and there's no back, so you're forced to like sit upright. Also standing desks have been, pretty popular recently for that exact reason. I like this amulet. Let's see what that's worth. So yeah, ergonomics, again, not really much reason to not use them. They're not really even like particularly expensive anymore. Nothing matches. Great. Okay, there's literally nothing that matches this. Wonder if I should put resists on this or life. Probably life, I guess. Sweet. And I'll put that up for, I don't know, maybe 1.5x or something?
But before you go telling friends, make sure you get them first. Order ahead on the McDonald's app.
There we go. Much better. My laptop was beeping at me. Yeah, so all of those things. So just to kind of recap, repetitive stress injury. So RICE, rest, ice, compression, elevation, right? Tylenol and ibuprofen. So the kind of as an aside here, the base for every like pain condition, whether it's back pain or post-surgical pain or repetitive stress or whatever you have, the groundwork for taking care of pain is Tylenol and ibuprofen. That's just like, that's pain management 101. So if you have anything, those are both great drugs. You can use them together. If you have questions about that, consult your doctor, but they are safe to use together. They work in different enough ways that they don't interact, other than being synergistic for your pain. Generally speaking, narcotics are bad, and we'll maybe talk about that at a later date. Maybe we'll talk about it now. Why not, right? Anyway, we'll finish up with repetitive stress. So, RICE, Tylenol, ibuprofen, physical therapy, essentially, which I need to do kind of right now while I'm thinking about it. So basic stretches for your hands and your fingers. You just basically, like, I do my best to sit in a neutral position, right? Like, you want your wrist kind of limp, I guess. Instead of like this, you don't want those keyboards that were supposedly ergonomic back in the day, like, but they make you flex your wrist, and that is not a natural position. That, necessarily requires some muscular contraction. So, don't do that if you can avoid it. You actually would want your keyboard to kind of slope downward so you could have your hand relaxed while you're still typing. Yeah, so physical therapy and, which, would include stretching, exercising, braces if braces, compression devices, and surgery. Finally, if it doesn't work, then they go in and cut that. Like for carpal tunnel specifically, they cut the tendon sheath and cubital tunnel, which is your elbow, I guess. They go in and basically cut the connective tissue that surrounds the nerve, the entrapped nerve, and which I guess is so for your carpal tunnel is your median nerve, and for cubital tunnel is your, I believe, your ulnar nerve. Let me make sure I'm telling you this right. Cubital tunnel syndrome. Yeah, so the three nerves that run down into your hand are the radial, ulnar, and, well, three largest significant nerves. Ulnar nerve, yeah. Doubted myself there for a second. Sorry. Anyway, the ulnar, median, and radial nerves. And they all they run from something called your brachial plexus, which comes off your spine, and it's your the nerve roots from so you have 7 cervical vertebrae, but you have 8 spinal nerves that come off, because there's one, they start above your vertebrae, so you have 1 through 8, C1 through 8, and then your thoracic vertebrae. So your brachial plexus comes from C5 to T1, so C5, 6, 7, 8, and T1. That's sort of not super relevant to what we're talking about outside of the nerve block issue. But yeah, just FYI. In case you ever want to really impress somebody with your knowledge of arm nerves for some reason. So yeah, surgery is the ultimate, I don't want to say goal, but ultimate therapy for pretty much all of that. You know, that's what you're trying to avoid. Generally speaking, you do not want to have surgery if you do not absolutely have to. You can very easily cause more problems than you fix in the long term. So there's we'll use back surgery as an example because it's something that I personally deal with all the time and know a fair amount about. So if you have back problems, which I personally do, I herniated a disc. Well, so I don't know this for a fact, but based on my symptoms and how it feels, or how it felt when I did it, I'm pretty sure I herniated a disc probably about 8 or 9 years ago. I was being an idiot and lifting too much with my legs, and just had this like electric shot down into my butt, and that's pretty telltale disc herniation. But I don't have any pain. I've never had any pain. But I do get kind of stiff. So this is all to say that back problems are common in younger people as well. And I see, people in their mid to late 20s getting single level discectomies all the time. I am here to tell you that that's probably a bad idea. You want to really exhaust all of your options first before going that route. You want to do physical therapy for, years, and, basically all of the same things that you do for repetitive stress injury. Like, anesthesiologists are not very creative people. We do kind of the same shit for everything. So, like, you can't really compress your back or elevate it. That's sort of nonsense. But you can ice it. You can rest it. You can use Tylenol, ibuprofen, anti-inflammatories. Back issues are primarily inflammatory things where essentially the areas around your nerves get inflamed and press on those nerves. So anything anti-inflammatory is going to be helpful there. So where I'm going with this anyway is a lot of people choose to have something called a fusion instead of just a simple discectomy, which is where you basically put like metal into your back to join two vertebrae to prevent them from like moving around the diseased, well, diseased is kind of a unfortunate term, but the affected nerve. And that usually works, but it's a short-term solution. People who have fusions, so think of, what's a good way to say this? So say these are your vertebrae, right? You've got a disc in between them. So the disc is kind of like, it's got this like gelatinous stuff in it called nucleus pulposus, which is basically just, I mean, it's just like a cushion, right? It's a cushion for your vertebrae. So when you have a discectomy, that's part of your disc. So your disc is like the nucleus pulposus with like this big, like tough fibrous coating around it. So when you have a disc herniation, it's where that fibrous capsule ruptures and the nucleus pulposus squirts out and pushes on a nerve. Or well, I guess it doesn't necessarily have to push on a nerve, but when you have symptoms from it, that it's pushing on a nerve. So when you have a fusion, you take that disc out and you go like this with those vertebrae. So the hardware basically like unloads these vertebrae, right? So you're the hardware, like the steel or whatever it is, I'm actually not entirely sure what it is, maybe it's titanium, that they put in your back, and they have some like weird alloys, but that's beside the point. Anyway, what happens is that segment of your back is unloaded that, you know, was causing the nerve problems, but you transfer that load to the levels above and below the fusion. So the data indicate that people with back problems who have fusions do better than people having conservative therapy, which is, you know, physical therapy and, you know, stretching, exercise, and all that stuff, for about 4 years. And then they start doing dramatically worse. And they have to have repeat operations, which, you know, then they encounter the same problems, and it's just like a vicious cycle, basically. So, you know, if you're 80 years old and not super active, like, you know, maybe a short-term game is in your best interest. You know, you're healthy and your quality of life suffering, and, you know, buying you a good, you know, 4 to 5 years is fine, and you're just going to deal with it after that. That's great. And, you know, it might last you a little bit longer than that because you aren't active, or as active as, you know, you had been in the past. Great. You know, that's a reasonable option. That's something that, you know, you should discuss with your primary care doctor, your surgeon, everybody involved. But if you are 25 and have a long life ahead of you, and presumably want to remain active for the remaining, you know, 50 plus years of your life, having a fusion can really send you down a bad path. And that could be a real tough thing. And that's where you kind of get into like long-term pain care and, you know, like repeat surgeries, like I said. And that's some difficult shit. Those are the people who typically get on opioids. Like, you know, Vicodin, oxycodone, you name it. Those are, you know, sort of bad words these days. You know, Purdue Pharmaceutical really pushed those through, particularly OxyContin. You know, with the pain is the fifth vital sign thing, that was really, 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 really bad for patient care, in my personal opinion. But yeah, they rammed that through and like altered medicine pretty substantially for a long time, and maybe permanently, honestly. They've sort of created an expectations that, you know, in Americans that you know, you're supposed to be pain-free at all times, no matter what. And that just is completely unrealistic, quite frankly. Anyway, so we'll get back to that in a minute, but where I was going with this is once you sort of open that Pandora's box of having surgery and you alter your normal anatomy, it's very difficult to predict how exactly that's going to go. But really your best option, or best possible outcome is nothing happens, right? So you are back to normal. You're not going to feel better. You know, best case scenario is, you know, like we were talking about back pain, is like your back pain goes away, right? Which is great. That's the goal, but it's not going to like improve you. It's just an opportunity for something to go wrong. People get surgical infections, they have failed surgeries, they need repeat surgeries. Obviously, you will have zero risk of a repeat surgery if you don't have surgery in the first place. So that is something that I strongly recommend. Surgery is an absolute last resort. That my experience supports that. The data support that. It's easy to think of surgery as a quick fix. Which sometimes, to be fair, like for things like carpal tunnel, it is. You know, when you have a peripheral operation like that, your risk of, you know, some huge complication is very, very, very low, and the probability of, you know, outright success and like relief of symptoms is very high. But you know, basically, the more central you go, like, the higher your chance of having some sort of long-term problem is. So like that means back, guts, brain, heart, etc. You know, like those are all things that you don't want to mess with if you don't absolutely have to. So back to this pain medicine concept. We had this, I mean, I cannot remember exactly when OxyContin came out, but I want to say it was about 15 years ago. Since then, so I mentioned the sixth vital sign. That is a concept that Purdue Pharmaceutical pushed nurses essentially to chart on their patients. So everybody has a temperature, a pulse ox, which is like measuring the oxygen content of your blood. So let me make sure I get all of these. So respiratory rate, pulse ox, temperature, blood pressure, and what's the other one? Oh, you know what? I'm thinking of ASA monitors, so it's the fifth vital sign. Excuse me. So now you have pain, pulse ox, respiratory rate, blood pressure, and pulse ox, respiratory rate, blood pressure, pain, temperature. There you go. Cool. Got it. It took a second. So anyway, what that did was basically provide an opportunity for nurses and patients to push Purdue's drug. So, you know, if the patient says, well, my pain's a 6 today, but my acceptable level is a 5, the nurse will come in and give them pain meds. And that, while I think that is rapidly vanishing from medical practice, and rightfully so, nurses everywhere still ask, you know, what's your pain right now? What is an acceptable level? What would you be okay going home with? Which to some degree is a useful metric, right? Like, you know, some people are going to sit there and tell you that they're a 10 out of 10 pain when they're, playing Candy Crush on their phone or whatever. And that's, you have to use like some level of judgment to call bullshit on things like that. Oh god. That was a lot of sparks and arrows. But, it's nice to have at least kind of like a baseline and know like what you're dealing with. But again, the sort of the whole purpose of Purdue pushing this extra vital sign thing was, it was a money grab. They wanted to sell drug, and that was a very, very effective way of doing it. We as Americans sort of have this, like, entitlement that, oh, you know what, I didn't turn Cat's stealth back on. That makes a difference. I was wondering why my charges weren't coming around. But yeah, like I said, we sort of have this feeling like everything should be perfect all the time, and exactly the way we want it immediately all the time. And Purdue just like, they just ate that alive, dude. They made billions and billions and billions of dollars off of that attitude. And they knew it. That's why they're paying. They're paying those billions back now. In various lawsuits. So, in the meantime, medicine is left with the scarred landscape that they, left behind. In any event, this is all to say that for a long time, there were lots of people who unnecessarily requested and were given opioids, and specifically long-acting opioids, which is OxyContin. So in case you don't know, OxyContin is extended-release oxycodone, and it is potent shit. And if you go to a pain management doctor, it is usually the first drug that they will take you off of, because it's very addictive, it's very abusable, and there's not really a whole lot of evidence, actually, that long-term opioid therapy is useful in chronic pain. There are lots of things that are, like Tylenol and ibuprofen, for instance. There's neuromodulation, which is so let's take a step back. So let's do types of pain meds. Okay, so types of pain meds. So you have oh cool, COX inhibition, which, so Tylenol's probably COX-3 in addition to a bunch of other stuff. Ooh, that's cool. I like it. Yeah, so it's COX-3 in addition to some other things. Tylenol's actually a very complex drug, oddly enough, and we don't 100% understand how it works, last I checked, but COX-3 I think is the primary mode. So I bought that, as an aside here real quick, I bought that Watcher's Eye. Oh my god. As Krust looks over you, he spits exiles, he mutters. As you pass him, you can smell the sticky stench emanating from his groin. You lick your lips. This is going to be fun, you think to yourself as you skip through town to murder innocent scientists just trying to figure out what gems do. He may not know it yet, but soon Groost will be begging for you to clean his impressive rod, and you can't wait. Thanks for the train. 100% worth the read. Fantastic. Okay. So. Oh, shit. So, Tylenol, COX-3 inhibition. So ibuprofen is in a class of drugs called NSAIDs, which is non-steroidal anti-inflammatory drugs. So NSAIDs, which are COX-1 and 2 inhibitors, there are specific COX-2 inhibitors, like Love this guy. Yeah, so, like, Vioxx was one, until it, you know, caused heart attacks in healthy young people. Or was it heart attacks or heart failure? I can't remember. Heart problems in healthy young people. Lewd. Right, so Vioxx, and the one that's commonly used now is Celebrex, as a selective COX-2 inhibitor. That is useful because the COX-1 inhibitors it can so NSAIDs affect your kidneys and your GI tract. COX-1 is mostly responsible for like causing ulcers and degrading your GI mucosa, like the lining of your stomach and stuff. So a COX-2 selective inhibitor is nice to not do that. But anyway, so there's all the COX inhibition. We inhibit lots of COX in anesthesia, lots of it. So there's that. There's opioids, which we talked about, and that's like Vicodin, or Norco, or whatever you want to call it. Hydrocodone, oxycodone are the primary ones that we use. Short-acting ones, there's a whole bunch, but fentanyl's probably the most common one. And that's unfortunately gained some street popularity thanks to some exceptionally stupid people who think that it's a good plan to snort or inject unknown quantities of it. That will kill you real fast, let me tell you. It is also way, way addictive. So please don't abuse fentanyl. That's a really bad idea. There are other short-acting ones, but that's kind of like anesthesia-specific. And if you guys have any interest in that, I can talk about those. But really, nobody else uses any of those drugs. Dilaudid's another fun one that lots of people know about. So there's other kind of more exotic things too. So there's atypical calcium channel blockers, which is like gabapentin or Neurontin. Lyrica, which is it's a what do you call it? It's a prodrug. So like you metabolize it into gabapentin, basically. What else do we have? So there's central alpha-2 blockers, which are like clonidine and Precedex, dexmedetomidine. Nobody probably knows what Precedex is, because that's again kind of an anesthesia thing. But clonidine's sometimes used for blood pressure too, in people who are like just totally out of control in their blood pressure and they just like need another med for it. There's that. There's so there's a receptor in your brain called an NMDA receptor, and blocking that is very good for pain. You may know that as the receptor that PCP affects, which it does. But ketamine also affects that receptor. Ketamine is a fantastic drug. Methadone affects that drug, or that receptor. Methadone also has some like partial opioid activity, if I recall. Methadone is another very, very complex drug that's sometimes pretty difficult to manage. But ketamine is usually the main one we use there. Another interesting NMDA receptor antagonist means it blocks that receptor, is magnesium. So you can give people magnesium infusions, and that will help with their pain too. What other pain classes am I missing? I think that's most of them. Well, there's local anesthetics too, so stuff like lidocaine. Lidocaine's probably the most commonly known one. There's a bunch of other ones. Cocaine. So kind of shifting back to the back pain thing, basically all of those things are better than opioids. All of those other classes of drugs are better to use than opioids. They generally, as weird as it sounds, using something in the same class as PCP for pain treatment. Did I? No, I didn't. I didn't finish this, did I? They have fewer side effects, so, which is crazy. It's like opioids cause constipation. Like, so one interesting thing about opioid drugs is that their side effects are mostly not something that you develop tolerance to. So like, you will develop tolerance to the drug, but not to the constipation and not to the nausea. So, you know, as you sort of fall down the opiate dosing rabbit hole, and some people have like really gone far down that hole. I mean, taken like, you know, several hundred milligrams of opioid per day. And like, for reference, I remember back in the day I had my wisdom teeth out. I took 1 5 milligram oxycodone and I was like high as hell. I was floored. You know, these are like astronomical doses of drug. That some people just like, that's their life. You know, unfortunately somebody has decided that that was good for them, mistakenly so, and sort of doomed them to a life of stupor and ineffective pain control. But you know, again, this all sort of circles back to like American like fix it now culture. So we as Americans use, last I checked, which was probably about 2 years ago now, we used 85% of the world's opioid drugs, and we are 5% of the world's population. Less than 5%. So think about that for a second. You know, some of that, to be fair, some of that is because, you know, we are a, you know, relatively rich and powerful nation, and we have access to things like that. But, like, opioid use per person is just through the freaking roof compared to, like, Europe and Japan and, you know, other similarly, like, wealthy and developed nations. It's totally out of control. I would expect that to have improved in recent times, but I have not seen recent data on that since the whole opioid addiction scandal thing kind of broke a few years back. But it's a huge problem. Huge problem. So that sort of leads me back to the refrain that conservative therapy is almost always the best. You want to exercise, you want to stretch, basically do everything you can to take care of yourself without, you know, having somebody cut you open. Let's go fight the Maven with my new and improved awesomeness. I'm totally digging this. Oh, I guess I had to start the encounter. I wondered why nothing was happening. There we go. You get ignited, sir. So I wonder if I ought to do the, I think I have the Conqueror's Invitation. I should probably do that pretty soon. I'll take that. That was pretty smooth. Pretty smooth. Okay, go get more. Yes, ma'am. What am I doing here? Heart of the Grove. No, I don't know why I got that one. Heart of the Grove sucks. Breaches. Just not feeling the breaches. 50% chance to spawn an additional monsters. Does that mean I get more harvest things? I don't know that I really want to do Nico. And none of this really, like... Well, I guess that helps with delving. No, I don't really like any of this. 5% chance to drop a breach stone for bosses. Double chance for bosses. And double breach splinters. Oh boy. I think I'd rather just buy the breach stones. Well, I guess that's why I got the harvest stuff, because nothing else is worth a shit. Well, why don't I just do this instead of... Wait a second. 2% to have the Sacred Grove? Eh, fuck it. Might as well do that. And then we'll go Nico next. Okay, so that was pain management. That was mostly non-invasive pain management, in a nutshell. Invasive pain management is not something that I... so that's a sort of tangentially related thing to anesthesia. You have to do what's called a fellowship, which is an extra year of training after your residency, to get trained in that. I have done a fair few interventional pain procedures, which usually are, well, we'll go over it in a second, but I could probably do it if pressed. You know, for some reason somebody just absolutely had to have an, epidural steroid injection, I could make that happen, but I'm not super proficient at it. I haven't done it in almost 5 years now. Actually, probably about 5 years. But I do know a fair, intellectually know about it. So the most common thing is in interventional pain management, which does not include, they're not surgical procedures typically. So there are a couple things you can do. So first is a lumbar epidural steroid injection, or just generally an epidural steroid injection, which is sort of a similar thing to like a labor epidural, hence epidural. Influenced by the elder, you say? Why, yes, I will do that now. So basically you just inject some steroid and local anesthetic in somebody's epidural space, which is so there's like a coating, a layer of connective tissue that houses your spinal cord and your brain. It's a continuous thing called your dura. The epidural is the space right outside of that, basically. And the drugs kind of, it's sort of like a little bit permeable to meds. And drugs just sort of leak through it and affect your nerves. So that's a useful way to acutely take care of back pain, and sometimes lower limb pain, or upper limb pain for that matter. So there's that. More invasive things include something called a spinal cord stimulator, which is for people who have chronic back pain, just all the time, despite proper management. And basically what it does is it institutes nerve noise. So speakers have a signal to noise ratio, and if that isn't good enough, you can't hear your music, right? So think of pain as the music, and the spinal cord stimulator as the signal to noise, is increasing the signal to noise ratio, or rather decreasing the signal to noise ratio. So basically you're muddying out those pain signals with the constant noise that the spinal stimulator is pushing out. And that is actually very effective for most people. The other thing that is permanently implantable is something called a pain pump. We just call it a pain pump. And usually what it is a you pump drugs directly into somebody's cerebrospinal fluid. And that is every bit as fucked up as it sounds. So usually that's for people who have basically cancer pain, Like, they have terminal cancer and they're going to die soon, and you know, you're just like making their life better while they slowly die, or maybe not so slowly die. It is a fantastic therapy for people who qualify for and benefit from it. There are some people who will kind of put them in patients who don't really meet the requirements, and, you know, similarly doom them to a life of opioid dependence, but with the added risk of, you know, having something permanently implantable in your body, which can, you know, malfunction or get infected, or, you know, just have shit go wrong at any time, theoretically. So that's not good. But, you know, for people with, you know, terminal conditions and chronic pain, they are just awesome. They are really, really, really useful. It's a very humane and sort of elegant way to take care of those people and make sure that they have, you know, a comfortable last few months. There are other things that you can do, like radio frequency ablations, which is where you literally go in with a like heated coil, basically, and kill a nerve. Like, you just heat the nerve up and temporarily like fry it. It will come back, like, you know, it doesn't like totally sever the nerve or anything like that, so you will get sensation from that nerve back, and sometimes that is an extremely unpleasant sensation when that nerve is like healing itself. But it does give people, like, you know, some degree of immediate relief, which, you know, can be a good thing. What else? I think I've pretty well exhausted my pain knowledge. The other thing that you can do for short term, we talked about earlier, is nerve blocks. You can theoretically put a catheter, a tube, next to the nerve that you're trying to anesthetize and put numbing medicine next to. And those tubes can stay there for about a week before they're, you know, too much of an infection risk and have to be pulled. But that could give you some like post-operative. Oh my. Well, that's nice. Maybe I should go do some synthesis stuff, huh? That's pretty cool. I haven't found a synthesis map yet this league. Sweet. Anyway, yeah. So yeah, that's a short-term thing. You can also do epidurals, like for labor. There's also something called a spinal, which is basically injecting local anesthetic directly into the spinal fluid, which is kind of like a one-shot, high-powered epidural. Basically, we usually use this for people having C-sections or maybe some sort of like lower extremity surgery, like a hip replacement or knee replacement or something. And you can theoretically use it for like an appendectomy or some abdominal surgery too. I mean, that's which a C-section is. Yeah. That's my anesthesia residency in, what, about an hour and change? Now you know everything there is to know. Perfect.